So, hello everyone. As we have already promised you, so what we are going to discuss is about the atrial fibrillation. A lot of times we have already spoken about the ablation part. I would say what is happening is considering the literally the epidemic of ablation, atrial fibrillation. I would say there are a lot of people, especially in the Western world as well, who do ablate, claim to be AF specialists, but we need to be understand atrial fibrillation is not just about signs and symptoms and the ablation, but it means quite a lot. It is literally like an epidemic, and it's a subject in its own. So we'll try to at least understand, especially about the primary care management, in fact. And why I love to talk about atrial fibrillation, especially, is as I had said, this is the last guidelines, and it does refer to two of my publications as well. In fact, so it's really a prestige and, of course, a great pleasure for your paper to be included in the guidelines as well. So, whenever you do work for on a topic, work with a full heart, give it your best, and then, of course, results will take time. Okay. Now, so one of the important things we are concerned about is what about the symptoms which these patients tends to have. So to tell you, like a typical patient, a lot of these patients can be asymptomatic as well. Of course, if there will be symptoms, we will be aware of such patients as well. What is the problem? What are they having? So let's try to focus. What are those asymptomatic problems? So as I had said, it can be pretty common, and especially the problem. What happens is if it is on a long-term basis, that is where you start noticing that, okay, these patients can be starting to become asymptomatic, in fact. And a lot of times they will be picked up in the general clinic. So, for example, in the clinic, those patients are under routine follow-up. So, one did a Holter or a ECG, and then, oh, there's some abnormality. Otherwise, unfortunately, a lot of patients, in fact, I would say up to 65% of the stroke patients tend to have atrial fibrillation as an etiology. And as I said it, so a lot of patients association with a complication like a stroke, heart failure, even thromboembolism as well. And that's where the diagnosis can be slightly a bit uncertain, in fact. So about symptoms, as we already spoke, okay, so they will be having cardiac symptoms, non-cardiac symptoms. Okay, the most commonly they tend to have is uh, breathlessness or dyspnea on exertion, palpitations, chest pain, syncope, dizziness will be there, fatigue. So there will be those patients who will be telling, oh, no, 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 I do not have any heart rhythm problem at all. But what happens, doctor, is whenever I go for a walk, I get feel fatigued, easily fatigued. I'm not able to do much of work. Okay, even they can feel fatigue, like even when they're in fact. And sometimes, in fact, what happens is there are episodes of urination. So, what is the polyuria may increase, and the reason for that is due to the release of a hormone called as atrial natriuretic peptide. Okay, and yes, in extreme cases, these patients may even have loss of consciousness. Can anyone say what could be the reason of loss of consciousness in atrial fibrillation patients? What could be the reason? Please use the chat box. Okay, I can see some answers. So, what are the possible reasons for that? Decreased stroke volume, very good. Dr. Uza, Dr. Say, wonderful, absolutely, absolutely. So that's a very common reason, in fact, due to which it can happen. So whenever there is atrial fibrillation, due to the atrial kick can be lost, and if due to that, what happens is there will be decreased cardiac output as well, and that's why a lot of times, especially during the atrial fibrillation episodes, especially at higher heart rate, the cardiac output will seem to be decreased. So that becomes really like a problem about that. So, as I had already said it, whenever we are speaking to such kind of patients, what we try to do is we have to try to ask to those patients if they do get any those symptoms which I was talking about, like the palpitations. How's the onset? How's the duration? How frequent is it? What is the pattern? How quick is it? How fast is it? Is it associated with some alarming symptoms like the chest pain, breathlessness, fatigue, or confusion, flushes, sweating, or even has it even influenced the exercise capacity as well? So once you have taken that, one of the important factors to be asked to the patient, is there any precipitating factors? Precipitating factors, I must say, we do come across a lot of times, especially working in the Western setup as well, like alcoholic cardiomyopathy or induced atrial fibrillation as well. So someone try to ask in detail as well, is there any history of drug intake? Is there any history of excessive alcohol intake or tea or coffee intake as well? What about some medications? So medications, can someone tell me what kind of medications can induce atrial fibrillation? So there are a lot of cardiotoxic drugs and all. So especially the ones which are used for treatment of cancer, in fact. So they can cause a lot of these kind of problems, in fact. And exercise as well. So exercise is, of course, really good, but someone who is doing too much of exercise. So someone who is doing too much of running activity, too much means, I mean, every day, at least if they are doing at least a few hours of running and all, or strenuous exercise as well. So especially in some of the athletes, it has been associated with atrial fibrillation. In fact, if someone is really exercising too much as well. Then there may be history of orthopnea, PND, or nocturia, or peripheral edema. Otherwise, one of the common things what you can even ask to the patient, how many pillows are they using during the night for sleeping? So if someone gives a history like they need more pillows, like three, four pillows, so then you should start becoming suspicious. Suspicious, why? So that is a natural or normal body defense to to decrease the amount of fluid reaching towards the heart or towards the lung, to decrease the pulmonary edema, and they will be using that. Okay. And yes, if you do come across flu-like symptoms, especially in recent times, always try to rule out COVID infection. Other than that, in fact, always consider myocarditis or pericarditis as well. You must rule it out. So there are a lot of significant associations. As I had said it, so if you, in the past history of findings, you must rule it out. What do I mean to say? For example, if someone said about arrhythmia itself, okay, that they have been getting some arrhythmia, try to go through the ECG, try to rule out these things. What about history of previous cardiac surgery? To tell you what happens is a lot of these patients who have had, I would say, like even for surgery, for the bypass surgeries, a lot of them will be predisposed to develop atrial fibrillation as well. Hmm? Wha How do you think rheumatic fever, history of rheumatic fever will increase the chances of AF? Okay, okay. So I can see in the chat that's good that a lot of people are answering. Good. Okay. Good. So I can so what happens to rheumatic fever is the one if you all will recall what is called as rheumatic heart disease. Okay. Yes. Infections can also precipitate atrial fibrillation. Thank you, Dr. Toma. Uh, then what happens is rheumatic fever is quite a lot associated with rheumatic heart disease. Rheumatic heart disease is commonly associated with mitral stenosis. Mitral stenosis, it will start narrowing the mitral valve, due to which there will be increased LA pressure, due to which it will cause the stretching of the left atrium, and that can itself precipitate that, in fact. Good, good. And as I already said about the alcohol history and all, so in fact, if there's a history of family, premature coronary disease, or even sudden cardiac death as well, that can also cause that. Then, similarly, if someone is taking thyroid, okay, thyroid diseases, so that is definitely a time that one should try to rule it out. Then, similarly, if someone is taking bronchodilators tends to be stimulants. In fact, they contain steroids, so they can again cause such kind of problems as well. Okay, and even with the yes age, very good, very good. So we are going to come up to it in the other causes as well, as you rightly said, even sex as well. Sex in this terms, like male are more predisposed for atrial fibrillation. Similarly, if they are Caucasians, race-wise, Caucasians are more predisposed for atrial fibrillation, in fact. Then during the physical examination, what you try to do is you must try to access for the pulse, both, not just at rest, but also during exertion. Check the blood pressure in both the arms, rule out, like palpate for the peripheral and jugular venous pulse, and also always try to rule out for the carotid artery bruit. And why is that? Please use the chat box. Okay, variable S1 in atrial fibrillation, there'll be no S1, isn't it? Because at least in my med school, what was I was taught is, S1 is the first heart sound. But what happens is in this atrial fibrillation, there is no P waves, right? So you don't see that. So if you don't see that, then what is going to happen? S1 won't be there, right? Bandaru, Dr. Bandaru, isn't it? Do you agree with me? Thanks for using the chat box. Good. So that's why. So whenever you are trying to do the examination as well, thank you, Dr. Anusha. So it's important to try to rule out the cardiac failure as well. So as I always say to you guys, like atrial fibrillation is a problem which doubles the risk of dementia, triples the risk of heart failure, quadruples the risk of stroke. In fact, okay. So heart failure as well. If you come across a patient with heart failure, try to rule out, do an ECG, and then even try to see for anemia. How about the yes, vagal atrial fibrillation as well, Dr. Toma? Yeah, I agree with you, absolutely. So similarly, if there's a patient with peripheral edema or the endocarditis, thyrotoxicosis, especially with thyrotoxicosis, interestingly, thyrotoxicosis or alcoholic liver disease, they are very important reversible causes for atrial fibrillation. So if you take care of the precipitating etiology, you can take care of them as well, of the treatment, in fact, in a much easy way. So why is ECG more important? I know we all will be looking for the, I would say like, for the, what are the, how is the response for the ventricular rate? How about the irregular beats, in fact? What else? What are the things which we should see that it makes us suspect atrial fibrillation? Suspect. So as I was telling you, so there are some of the common things which you should try to see on the ECG. Whenever it is irregularly irregular, okay. The other thing to have a look is about the rate. If it is more than 100 beats per minute, especially in an elderly patient, that's where it becomes really important, especially if there is a patient whenever you are doing a permanent ventricular pacing as well. So what happens is with passage of time they may start developing symptoms of heart failure or even the irregular rhythm as well. Okay, a lot of times if there's a broad QRS as well, try to rule it out, because a lot of times atrial fibrillation can be, I would say, like up to 5%, they can be present with accessory pathways, okay? And try to confirm the diagnosis whenever, as I said it, if there is a typical ECG trace. Otherwise, if you are finding it difficult to see for the P waves as well, and sometimes if you notice that there are variable and completely irregular baseline, in fact, and which can be most of the time seen, especially in the V1 lead itself. And especially about the ventricular response in AF, one has to be careful to be able to understand the AV nodal properties. So AV nodes are like great floodgate control. Why or how? In the sense, they will always allow up to a level to cross. So up to beats of like 110, 120, 130. But when it crosses beyond that, the number of impulses in flexion, so it will start, to control that. Okay, more than 130, they will not allow. So the another important thing to which we should keep it in mind for such conditions is called as about the level of vagal and sympathetic tone. So because on the basis of that as well, the ventricular response can be affected. It can go sometimes low, it can go sometimes higher as well. So then there are a lot of drugs, the medications are there, which can be further affecting the AV nodal conduction. I'm sure you all are aware, like the beta blockers, the calcium channel blockers, especially non dihydropyridine. Can someone give me some example? So, what are the examples of non dihydropyridine calcium channel blockers? Verapamil, in fact, to tell you what happens is they tend to have a negative impact, okay? But the other also thing is like they tend to cause less vasodilation and more cardiac depression. So that's why we will prefer for that, isn't it? Oh, yes. See, we have such a smart, Students. Dr. Uza, wonderful. Dr. Uza was the quickest one, I would say. Dr. Tuma, Dr. Banjuru, good. So, and digoxin, of course, as well. Can someone tell me what is the class of antiarrhythmic drugs for digoxin? Under in which group of antiarrhythmics? Ooh, Dr.
Calcium.
Uza said class. Please use the chat box because this is for benefit of everyone. We all can see the chat box who is writing what, and it doesn't create any audio interference as well. Okay. Dr. Raja said class 5. Hmm, interesting. Okay, some few people are now changing the answers as well. Good. Actually, to tell you very frankly, there's no the the so what is called it is called as von Wuggen William, hmm? And Singh classification it is called as, okay. So in that there are actually four of them. There's nothing called as class 5, but it has been just for the sake of seeing it is said as class 5. So they have not been under classification of any of the drugs. Digoxin. Can someone tell me another example of antiarrhythmic drug which has not been classified yet? Digoxin, right now we said it. Adenosine, good. Miscellaneous, good. That's the way. Adenosine, yes. And digoxin, adenosine. What else? There are so many sins. So, wonderful. I got the good answer. Dr. Shekhar. Magnesium sulfate. Indeed. That's the way I like it. That's the way I like it. I need active participation from you all. Wonderful. Dr. Tuma, Dr. Sangamitra Ramiti. Good. I'm really glad that you guys are paying much attention and also because we had taken some sessions also on the antiarrhythmic drugs and we said it about it as well. Wonderful. Good, good. I'm very happy. So, and whenever you come across these kind of patients as well, always, atropine is not an antiarrhythmic drug actually. Okay. Okay. So now what happens is we should try to always, whenever there's also any history of or any signs of structural heart disease, always try to get a 12 lead ECG and rule it out. Rule it out in terms of, for example, I mean to say is you should try to rule out any old myocardial infarction, then left ventricular hypertrophy or bundle branch block, or even ventricular pre-excitation as well. So whenever one of the key things to always remember is a lot of times what is called as paroxysmal AF. So the patient may not be having those AF episodes always. So there will be a lot of times when the AF episodes will not be there. So what will happen is the patient will be having what is called as the silent AF. And then, so that is the time what happens is you will have to start considering for ambulatory ECG monitoring. In that, so then what you can try to think is if there is a acute patient who comes to you, presents to you in the emergency room. So what are those red flag signs, I would say? Red flag signs, if I would say is like try to think if there's alleviated symptoms of breathlessness, chest pain, even loss of consciousness or, as well, or there's hemodynamic stability problem, or otherwise if there are patients at greatest risk from the hemodynamic instability, in fact. So how do you say that? The instability from the hemodynamic perspective. There's a high ventricular rate, like more than 150. There's ongoing chest pain. If there are any critical perfusion problems as well, then you must try to, you raise your red flags and try to take care of them at least on a priority basis or on an urgent basis. Similarly, if you come across a patient who has already developed a complication of AF, that means like stroke, the transient ischemic attack, or even the acute heart failure as well. A lot of times, so what will be the differential diagnosis? So you think, okay, it is atrial fibrillation on the ECG. So what are the differential diagnoses which you should think for? Please use the chat box. Let's see who gives the quickest answers. At least there are three different arrhythmias which you should rule out, I would say. So what are those arrhythmias? As I said, okay, I'll try to repeat the question. Atrial fibrillation, you really think that this is atrial fibrillation on the ECG? And then what will be the differential diagnosis for atrial fibrillation rhythm on ECG? Good, good, good. Flutter, supraventricular tachycardia, good. Multifocal tachycardia, yes. Atrial tachycardias, as you already said it, in fact, as well. Good. And atrial ectopics as well. A lot of times can confuse the diagnosis. So now you are certain about the diagnosis. You have taken a good history. You already did the physical examination as well. You accessed for assess the patient for red flag signs as well. Now what will you do? You want to do some investigations. So in the investigations, what do you try to rule out? So I already said it, a lot of those are precipitating factors, isn't it? Like how about the blood levels, the kidney levels as well, because they can themselves be an important precipitating factors for that. Thyroid function tests, as I already said, the liver function as well. And because on the basis of CHATS score of the patient, you may have to consider to anticoagulate them. So you can also try to get a coagulation screen, like the APTT, the INR levels as well. Okay. Would you do a chest X-ray for atrial fibrillation patient? Would you see it in the hospital? Would you do a chest X-ray? And why? Okay, yes, yes, okay. So my decision was not bad of thinking of doing the chest X-ray. Why is that? Pulmonary edema, okay. Before that, do just in simple things like sometimes, if what about the lung cancer? How about the heart failure? Because these are important basic etiologies, in fact, isn't it? And then, of course, a echocardiogram as well. And if you're thinking, especially inside of the risk factors for coronary artery disease, then try to do a stress test as well. So, about the causes, the etiology, as I had already said it a lot of times, ischemic heart disease, rheumatic heart disease, hypertension, the sixth sinus syndrome, even the WPW as well, or if there's any structural defects like in terms of atrial septal defects or atrial myxomas, or if there is a pericardial disease. So it's not always about the cardiac causes. Okay? There are a lot of non-cardiac causes as well. So which we, some of them which we already said it about the infections like the pneumonia, electrolyte depletion, lung carcinoma, or the intrathoracic pathology, the pulmonary embolism, or the thyrotoxicosis as well. So once we know about the causes, like including the cardiac, non-cardiac causes, what are the different risk factors now? What are the different risk factors which can cause atrial fibrillation? Okay, good, good. I'm seeing very good participation. I'm really glad. We have a very participating crowd. That's what I always like, okay? I'm pretty happy with the quality input of our students as a program chair, okay? Wonderful. So, so the risk factors, as I had already said it, the sex, the age as well. In fact, what happens is, to give you an example, in 60s, people will have an incidence rate of like 1 to 2%, in fact. But someone goes into 70s, the incidence rate can go up to 5 to even 10%. When someone is in 80s, nearly 25% of those patients will have atrial fibrillation. And if someone goes in 90s, nearly one third, nearly 35 to 40% of those patients will have atrial fibrillation. So much is the rule of age. But yes, okay, what are the causes for atrial fibrillation in young patients? That becomes an interesting question. So that can be a question in your MRCP as well. It can be a question in your MCQs as well, in your board examinations as well. That can be a pretty common and popular question. What are the causes of atrial fibrillation in an infant, 2-year-old baby? You get a ECG done and you say, oh my God, this is atrial fibrillation. What is the reason for that? Excessive coffee? Oh my God. 2-year-old baby. Krutik, Dr. Krutik, Dr. Uza, 2-year-old baby having so much of coffee? It's okay. I mean, the differential diagnosis you gave is pretty good, but for adults, I would say. The 2-year-old baby, you got the ECG, you saw atrial fibrillation. Good, wonderful. Cardiomyopathy, atrial septal defects, wonderful, very good. I'm very happy to see that. Yes, indeed. Otherwise, if there's any history of previous cardiac surgery for the baby, then there's any congenital heart disease, if there's associated structural heart disease as well, try to rule them out. And then the valvular diseases, in fact. And coming to the other adult causes and all. So, for example, what happens is they can be associated myxomas, or even those emotional risk factors and all, in fact, or the physical or the emotional risk factors. Okay. One of the important things to understand is the types of atrial fibrillation. So, yes, paroxysmal atrial fibrillation is a type which is self terminating, usually within 48 hours. And the persistent AF is the one when the AF episode tends to last longer than 7 days, or it requires termination by cardioversion. Okay. And then comes the long standing persistent AF, in which it has lasted for 1 year or longer, and when it is decided to adopt a rhythm control strategy. And finally comes the permanent AF. Permanent AF is when there is arrhythmia is literally accepted by the patient or the physician, that nothing much can be done, in fact, for such kind of patients. So there is also a scoring system from the European Heart Rhythm Association. As you can see, class 1 is no symptoms at all. Class 2 has mild symptoms, class 3 has severe symptoms, and class 4 that the patient is not able to do the usual activities and the symptoms are quite a lot disabling, in fact. Have you all heard about lone AF? So, what is lone AF? Varieties which tend to have a normal or without any structural heart disease. When you get an echo done, echo is pretty normal. There's no structural heart disease at all. So it is considered more when there is no cardiovascular disease, there's no hypertension, there's no abnormal cardiac signs on physical examination. You did a chest X-ray as well, and you saw that okay, this seems to be pretty fine. Okay, and of course, there are implications of labeling patients with diagnosis of low atrial fibrillation. Is pretty low. Most of the times, what happens is these patients will be the age will be more than 65. They tend to have a low stroke risk. In fact, less than 1.3% over 15 years. And also, the probability of stroke in young patients with lone AF, of course, although tends to increase whenever there's increase of age, there's development of additional risk factors like the hypertension. In fact, so those lone AF patients should be followed up on a regular basis to monitor the development of additional risk factors. So, but the paroxysmal AF, already we have said it, it is self-terminating, especially within 48 hours itself. Okay, they can be, most of the times, I would say they can be pretty symptomatic. The time, they can be asymptomatic as well. Okay, and a lot of people, I mean, we can understand the human psychology is like, oh, everything is fine, you should believe in yourself. This is what a lot of people are taught. So they tend to ignore a lot of those symptoms. So that's why even if there will be paroxysmal AF, a lot of times those people can ignore it. Like, oh, no, 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 it's okay. And another thing, which is important, that uh, we should be careful which antiarrhythmic drug is being started where. For example, amiodarone or sotalol or even flecainide, better to avoid starting them on a primary care. So what about the persistent AF? So paroxysmal AF, as we said it, less than 48 hours. But persistent AF is the one which lasts more than 7 days. Okay, and it will need a termination by cardioversion. So one has to shock the patient, in fact. Okay. Then comes the long-standing persistent AF. Long-standing persistent AF is the one in which it has lasted more than 1 year, in fact. And then, of course, the decision has been taken to think for a rhythm control strategy. Okay, that's why it becomes more important by then. Paroxysmal AF, persistent AF. One of the important complications associated with these patients is the stroke risk. As I had said it, there's a pretty higher association. And in fact, as I said it, even those stroke patients who come to the hospital, 65% of the times, detected or undetected, I would say, etiology is atrial fibrillation, in fact. So that's why it should always be kept in mind. And for such kind of patients, atrial fibrillation patients, always try to assess if they have diabetes, hypertension, especially the age as well. So one of the other important things, especially whenever you're thinking of starting the anticoagulation, the important thing is we should try to see, do they fit? Are they suitable? For example, for anticoagulation, how do you see that? What is the scoring used for starting anticoagulation for the atrial fibrillation patients? So this is what is called as Chance-Fax 2 scoring. So in that, what do you do? So in that, what happens is you always try to see the score, of course. So there are only times when the score will be given 2 marks. Rest of the times, you always give only 1 mark. So what are those two? What are those important things where one should give 2 marks? So there are only two conditions, as I said it. One is the age, and the second one is if someone is having a risk of TIA, someone has had history of stroke. That is the time, okay? So once, and other than that, cardiac failure, hypertension, age 65 to 74 years, you give one. D for diabetes, S for stroke, vascular disease, okay? You tend to give them, and if the score is 0, there's low risk. So for example, for them, those patients, you did not start them on any medication, any anticoagulant at all. If there is 1, yes, you have to think of starting. So this is an important thing for everyone to know. But whenever we are starting as well, we should also outweigh or try to see for the has-bled scoring. Has-bled scoring is to see for the bleeding risk score. Has-bled, hypertension, abnormal renal or liver function. S is for stroke. B is for bleeding risk or bleeding history, bleeding predisposition. L is for labile INR. E is for elderly. So elderly patients more than 65 years will always have a high score for chances for bleeding as well. And even for drugs or alcohol concomitantly. And why am I talking about that? Because especially drugs like edoxaban, especially they have good interference with antiarrhythmic drugs. Okay, so that's why you give 1 point for all of these parameters, which we had already said. If someone has risk like score of 3 or more, it will be called as high risk. So you have to be careful about, you want to start them on warfarin or should it be aspirin itself? Okay, so if there's an elderly gentleman, you should think rather than aspirin a lot of times. If there's a, but, with the warfarin compared to warfarin. So the bleeding familiar, I mean, similar to the warfarin, especially in the elderly. And what has happened is a lot of people know, they tend to say, oh, elderly people and all, they may fall and all. But it seems what has happened is really there has been overstatement of the risk of falls. Okay, so that's why don't be worried about that. In fact, and the other thing as well is about the anti-thrombotic therapy, as I already said, it is all of the patients should be anticoagulated unless and until we said it like there's low risk patients includes the lone AF, the younger patients. Otherwise, if there are contraindications are present as well, if there's absolute benefit of vitamin K antagonists, okay, for example, like warfarin or for stroke prevention, okay, and then if there are patients who are 75 years and older. And if warfarin is being offered as taken, okay, because it's clear there's no use of taking aspirin with this. And of course, it can increase the risk of bleeding as well. So the other thing to be kept in mind is the ones AF with mechanical prosthetic valve. So what is called as the valvular AF. So for such kind of patients, ideally always vitamin K antagonist is recommended. For mitral valve, the INR should be higher. For example, aortic valve is like up to 2 is fine, then around 2.5 in the mitral position. And similarly, as even for those patients, as we already said it, there are only few conditions in which you should not offer them anticoagulation, either very high risk, otherwise low in AF, otherwise Chanfless score is 0 in fact as well. Okay. And always remember that yes, AF patients with age more than 75 years will be having a significant stroke risk. So this is what I would really like you all to keep it in mind for sure. Are there any further questions? Are there any further questions? Okay. I was pretty happy to see the participation of everyone and all, especially for today. It was really good participation from everyone and all. And I was pleasantly delighted to see this as well. And I'm pretty happy for all of you. And yeah, I would say make use of this a little bit extra free time, which everyone is getting, especially during the Corona times and all, because this is very, very important and make use of the best out of it, I would say as well. Okay. So I would suggest everyone a really good day and enjoy learning. Okay. Take care. Have a nice day. Bye bye.
Thank you so much, sir.
Thank you.
Thank you,
Bye.
sir. Bye, sir.
Bye.
Students, a feedback poll is running in the session. Please provide your feedback.